There's always individual variation, but they'd have to come off slowly.
How slowly?
It does depend on a lot of considerations. For example, whether someone wants to get pregnant. These are real things that's not minor. I mean, a lot of people, come off medications because they want to get pregnant.
But let's say we wanted to reduce withdrawal symptoms and the dangers that could potentially come with protracted withdrawal.
Well, fluoxetine is actually one of the better medications from which to come off.
Because of half-life.
Exactly.
Yeah.
So it kind of self-tapers. There are other ones that
but
are
at
harder
still
to come
some
off.
point that it's removed, like the drug is removed from the receptor, right? And now the body is reacting to the absence of it, even, at some point, right? So what
I'm not denying that medications have side effects. There's no doubt about it. And I'm also not denying a lot of the reports you're talking about, the case reports, your patient's experiences.
Yeah, these aren't side effects. This is a withdrawal effect.
I'm also
so in my community, psychiatrists in my region here are getting people off 3-4 psychiatric drugs in a 1 to 2 month period of time. They're getting.
I believe you.
Yeah,
I believe. You.
And they're psychiatrists.
I understand.
And I'm a psychologist, and I don't want anything actually to do with this, but I've been thrown into the conversation, obviously, because I'm having the conversations with people. So people around the globe contact me. Can you help me get off this drug? Is there someone you can refer to me? And the overwhelming psychiatrists in the United States I have conversations are like this. You've never heard of the Maudsley approach or hyperbolic tapering, or even aware of the epidemic of withdrawal.
That's different. Trust me, I know how to use medications and I know how to take people off medications. There's no doubt about that. Whether someone uses the Maudsley approach, whatever, I don't even know what that means. But trust me, I know how to take people off medications and put people on like taper and withdrawal.
I think psychiatrists know how to put. That. I think psychiatrists know how to put people on drugs. I don't think they how to take them off. How long would it take for you to get someone off Effexor?
Again, it depends on the dose. It depends on the person.
Full dose,
depends on what
10 years.
Medications.
Because this is what we're seeing. People on Effexor for 10, 15, 20 years now?
See, what happens is you start with Effexor. So with Effexor, what you would do is because of this low half-life, you would generally first cross-titrate them to something like sertraline or fluoxetine. And that's how it works.
Yeah, that's what we're seeing, and we're seeing horrible results from that.
Right. But that's the best. Listen, nothing is perfect, but that's the way to do it. And
I disagree.
Sometimes it works, and sometimes it doesn't work. But
that's not good enough. That's not good enough for the people who are harmed. So it's not perfect. Sometimes it works. Sometimes it doesn't. When there's a better way. There's a better way. Hyperbolic tapering is small reductions, like 10% reductions in dose, like a month, 10% reduction a month. And sometimes it takes years for people to get off the drug, including a reinstatement of a very low dose near the end of it. And we're seeing much better outcomes because what's happening is they're doing that. Psychiatrists are doing exactly what you described. Like you're prescribing another drug to get off of one drug.
One way.
You're doing it fast. They're having withdrawal reactions. They come back into the office. The psychiatrist says, here's your mental illness returning.
I hear you.
Do you understand that's your colleagues? Like your mental illness. This is why you need to be on the drug forever.
I wouldn't paint so large of a breath. And trust me, I mean, I think you said that's hyperbolic tapering. Is that what you called it?
Hyperbolic. And I'm not being hyperbolic.
No, I understand. No,
that's a standard of care.
I hear you. That's a phrase. I've never heard that phrase before, but that just describes slow tapering, and that's fine. I mean, we're totally familiar.
It's a little bit more. There's a curve in place, and there's a process involved in it.
But that's like how people on other not related to this podcast, or maybe, I don't know, I haven't listened to every single one of your episodes, but many of them. I actually appreciate a lot of what you do. But that's like how I hear in a lot of podcasts people say that, oh yeah, medical students receive no training in nutrition. And it's at first you think
very
maybe
limited.
That's true. No, but I mean,
or poor training.
But then you realize,
like don't eat red meat, like nonsense like that.
But what's nutrition? Nutrition is biochemistry. I mean, medical students get more than a biochemistry. I mean, that's what nutrition is. I mean, just because I don't know that something is called hyperbolic tapering doesn't mean I understand. I'm not familiar with how to, different methods for tapering people and, discontinuing medications. But I wanted to get to, no, there was another important point. Oh, gosh. Oh, yeah. Just in terms of the whole chemical imbalance theory, whether SSRIs would work, I did want to mention people use tryptophan depletion to, decrease serotonin and see whether that causes depression. That's a relatively weak way of decreasing serotonin. If you actually decrease serotonin and dopamine using alpha-methylparatyrosine, or what happens with people when after they use cocaine and LSD, they have a crash, which is what happens when you have AMPT. You immediately become depressed and suicidal in most cases. So again, there are lots of I'm just using these data to illustrate that there are lots of lines of evidence that support that SSRIs would be effective, or why they might be effective. Why we are pretty confident about the chemical imbalance theory and all these sorts of things. There's so many other points I wanted to get to. I've forgotten. You made a lot of good points. Oh yeah. I did want to mention. I want to validate a lot of. Most of what you're saying. Not all of it. I don't know as much about pharmaceutical companies. I do know that all trials now are on clinicaltrials.gov, and if they're not, one wouldn't be able to. Certainly, a pharmaceutical company wouldn't be able to use it as a registration trial. But yeah, I want to validate, like you said, totally 1 in 4, 1 in 5 patients are being prescribed psychiatric medications in the U.S. Many of them may be prescribed inappropriately. Most patients are prescribed psychiatric medications from their primary care physician, who may not know how to use the medications as well as a psychiatrist. I understand that you feel that psychiatrists aren't maybe much better than primary care physicians.
No, that's why it's being done. There's.
I figured I could make that.
Yeah.
I could claim that.